Thank you so much, Dr. Najwa, for organizing this meeting, and thank you so much, Astellas, for giving me this opportunity to present the clinical burden of FLT3 positive AML in Saudi Arabia. This is the disclaimer of the Astellas, and these are my objectives. We'll try to talk about the epidemiology of AML. We'll discuss incidence and prevalence of AML in Saudi Arabia. And we'll talk about the prognostic relevance of some of the key mutations, but with particular focus on FLT3-mutated AML in Saudi Arabia. And we'll talk about the clinical burden of the FLT3 positive AML in Saudi Arabia. And we'll try to emphasize on the need to have FLT3 inhibitors-based therapy available in the country, as this is an unmet medical need to treat FLT3 positive AML in a frontline setting as well as in relapsed refractory setting, as there is very narrow window of opportunity to treat these kind of relapsed refractory patients, those who have FLT3 positive AML. So let's begin with the statistics in the United States. How commonly acute myeloid leukemia is diagnosed there, and the prevalence of acute myeloid leukemia in the US. So the rate of the newly diagnosed AML cases per 100,000 was 4.3 in 2017, and the death rate was 2.8 per 100,000 in 2017. And the lifetime risk of developing cancer is about 0.5% of the total population in 2017. And the prevalence of the acute myeloid leukemia in US was about 64,500 cases of acute myeloid leukemia in US in 2017. And it is estimated to have around 20,000 new cases of AML will be diagnosed in 2020, and the estimated deaths due to AML is approximately 11,200 with a 5 years relative survival of 28.7%. Now let's move to the cancer registry of Saudi Arabia 2015. This is the latest cancer registry report that we have, and according to that, leukemia is the 5th most common cancer, with the total number of cases of around 700 cases of leukemia were diagnosed in 2015. And acute myeloid leukemia was the 2nd most common cancer, 2nd most common leukemia, with a total number of cases of 130 cases of acute myeloid leukemia were diagnosed in 2015. But then we also have the Global Cancer Observatory report for Saudi Arabia, which has shown, that was published in 2018, a couple of years ago, that had shown the total number of leukemia cases were actually more than double in 3 years when you compare it with 2015. In 2015, we had 700 cases of leukemia. In 2018, according to this report, we have 1,500 cases of leukemia, and that means it's more than double. And if we extrapolate this information and try to find out how much is probably estimated number of newly diagnosed cases of AML, so we're talking about at least 258 cases of AML are expected to be diagnosed in 2018, and probably we are close to 300 cases of newly diagnosed AML as of now in 2020. And not only this, leukemia was 5th most common cancer in 2015 cancer registry, and now it has become 4th most common cancer, according to Global Cancer Observatory report. And based on the cancer registry report that we discussed, the incidence of AML among the Saudi national is about 0.65 to 100,000 persons, and the global prevalence rate of the acute myeloid leukemia is 0.6 to 11 per 100,000. We don't know yet how much is exactly the prevalence rate of acute myeloid leukemia in Saudi Arabia, but I have extensively asked different hematologists, and I personally have this assumption that we have around 1,500 to 2,000 cases of acute myeloid leukemia in the country, and the population of the country is 34.8 million as of now. And if we believe this figure is approximately true, so then we are talking about prevalence rate of AML in Saudi population is nearly 4 to 6 per 100,000. And as we're talking about FLT3 positive AML in Saudi Arabia, and we know from the published literature and from the NCCN guideline that about 35 to 40% of the acute myeloid leukemia patients they have FLT3 mutation, and the most commonest FLT3 mutation is FLT3-IDD mutation, which has a significant prognostic relevance as well as it has the predictive biomarker. And the prognostic significance of the FLT3 TKD is probably still debatable, and we have about 30% of FLT3-IDD positive AML, and 10%, 5 to 10% of the cases of the AML are FLT3 TKD positive. So the total sum is around about 35 to 40% of acute myeloid leukemia patients they have FLT3 mutation as per NCCN guidelines 2020. If that's true, and we assume that we have 1,500 to 2,000 cases of AML, so we're talking about around 600 to 800 cases of FLT3 positive AML are prevalent in Saudi Arabia right now. And we don't have therapy for these kind of patients as of now. AML is really an aggressive and fatal disease, and its behavior is really aggressive among all the leukemias. And one of the study in UK was published in 2017 had shown that around 32% of all the leukemia cases in UK were AML, the leukemia, acute myeloid leukemia, the second most commonest cancer. 3,152 cases were diagnosed in 2017, and there were 2,598 deaths in 2017 were recorded. Around 25% of the patients with AML are estimated to be refractory to treatment, and more than 50% of the patients with AML are estimated to relapse. As of now, the AML is diagnosed by the WHO statement, and that's pretty clear statement that it has the some blast count consideration, and then you do the bone marrow biopsy. And the bone marrow finding should be consistent with AML with the blast count consideration of having blast more than 20% or equal to 20%. And in some situation, no matter what percentage of the blasts you have in your patient, but if they have the AML defining cytogenetics such as core binding factors, which is translocation 821, inversion 16, translocation 1616, this is still considered as AML. And also, WHO system has replaced the prior French-American British classification of acute myeloid leukemia as it was updated in 2016, and now there are 5 different classes of AML as per WHO classification. That's a very important slide, and it talks about cytogenetic and molecular mutation and their prognostic relevance. And basically, it differentiates AML into 3 different categories: favorable, intermediate, and adverse risk. And it has more prognostic significance and relevance. The patient, those who have favorable risk, they have cytogenetics, core binding factors, and coupled with the NPM1 mutation or SEPA double mutation, and they should not have FLT3-IDD mutation, and that's favorable risk. And these are the patients who are gonna receive induction remission therapy followed by consolidation chemotherapy, and they do pretty well with the chemotherapy, especially the core binding factor. They have the best responsiveness prognostic indicator for high dose cytarabine. But the patients also have adverse risk. They basically include the chromosome 5 and 7 abnormalities, or complex karyotype, but those who have MLL gene rearrangement with Philadelphia chromosome. So basically, these patients, or even patients having normal cytogenetics, when they have the FLT3-IDD mutation or other mutation, then they are adverse risk mutation and the adverse risk AML. And these are the patients who are not going to do well with the chemotherapy. So you have to give remission induction therapy, and the best consolidation therapy is the allogeneic stem cell transplantation. And then we have the category of intermediate risk AML. So this is still debatable. The role of the transplant is still debatable. If you're a transplant center, you will definitely do the transplant, like we are the transplant center. And if we have any patient with a c-KIT mutation, for example, with the even with a core binding factor or normal cytogenetic with a c-KIT mutation, we do transplant these kind of patients. And we have many mutations which have prognostic significance. One of the most important mutation is the FLT3 mutation, and it really offers poor prognosis in terms of shorter overall survival and shorter disease-free survival. And when they relapse, it's pretty difficult to get them into complete remission, and they have very short overall survival in a relapsed refractory setting. But it's also a predictive biomarker, as we have the target therapy for the FLT3 mutation, and in frontline setting we have mitastatin. We can combine it with with the chemotherapy like 7+3 and second-line setting in relapsed refractory AML. There is very promising FLT3 inhibitor gilteritinib, which has been compared with the salvage chemotherapy, and it has shown significant complete remission and complete remission with incomplete recovery, about 34% in a middle trial when it was compared with the chemotherapy. And it's pretty difficult to get those patients in the relapsed refractory setting having FLT3 positive AML to get them into remission and take them on road to the transplant. And gilteritinib has really made it possible in significant number of patients to make them to the transplant. NPM1 and SEPA double mutation, they have good prognosis, and c-KIT mutation has the bad prognosis. This slide really talks about like complexity of the genomic landscape in AML patients with the FLT3 mutation is the most commonest mutation. We're talking about 40% of patients in NCCN guideline, they have FLT3 mutation, and around 30% of patients they have FLT3 IDD, and 5 to 10% of patients they have FLT3 TKD mutation. And this is prognostic as well as the predictive biomarkers. And other predictive biomarkers are IDH1 and IDH2, as we have the inhibitors of IDH1 and IDH2, and these are all the worst prognosis mutations. So what is FLT3 gene? FLT3 gene is really an important gene which is responsible for hematopoiesis. And FLT3 gene basically provides instruction for making a specific protein called FLT3 FMS-like tyrosine kinase, receptor tyrosine kinase, which is expressed on the CD34 cells of the pluripotent stem cells. And that's responsible for survival, proliferation, and differentiation of the pluripotent stem cells into the different types of the blood cells. And when this mutation occurs, then there is a disruption of the survival and proliferation and differentiation of the pluripotent stem cells into different lines of the blood cell, then leukemogenesis happens. And that's pretty difficult to treat this kind of AML. And for that, we really need to have specific target therapy incorporated into chemotherapy or used as monotherapy in relapsed refractory setting. So there are two types of mutation. There is FLT3 IDD mutation, which is found here is internal tandem duplication, and that's really associated with the worst prognosis. And then we have the FLT3 TKD mutation. The earlier studies published almost 20 years ago, one of the studies published in Blood 2002 had shown the prognostic relevance of FLT3 mutation with overall survival. And when they looked at the prognostic relevance, they found out that those patients who had FLT3 mutation, they had very shorter overall survival in comparison to those patients who had no FLT3 mutation. And then we had the FLT3 the A35 mutation, which is now recognized as TKD mutation. It has a slightly better overall survival in comparison to ITD, but it has inferior survival in comparison to no FLT3 IDD mutation. This FLT3 mutation is really a marker of very poor prognosis in terms of shorter disease-free survival. The risk of relapse is very high, and they have shorter overall survival. And even in relapse setting, there's another study which was published in leukemia research 10 years ago. They looked at overall survival, prognostic relevance, and they found out that those patients who had FLT3 mutation, they had very shorter overall survival when the patient had first relapse, FLT3 positive AML patient, when they had a first relapse in comparison to those patients who do not have FLT3 mutation. And not only this, it's very difficult to get these patients to complete remission. But now we have a randomized control trial, admiral trial, which I was talking about, had shown that around 34% of patients use of the gilteritinib in relapsed refractory setting. 34% of the patients were able to achieve complete remission and were incomplete recovery, and they were able to be transplanted. And then you can use gilteritinib in post-transplant setting. So these are the examples of the predictive biomarkers for FLT3. We have mitostatin in frontline setting. You can incorporate it with 7+3 induction therapy, and then with the consolidation therapy, and then you can use it post-transplant for 1 year or until the disease progression. And similarly, you can use gilteritinib. I think because of the Saudi FDA regulation, it still does not want to show the name of the drug here, but I would like to say that FLT3 is a very promising drug in relapsed refractory setting. Then we have ivosidenib and inacinib in IDH1 and IDH2 positive mutation in frontline as well as in second line setting, and gemtuzumab ozogamicin can be used in CD33 positive AML patients. So that's the trial in 7+3 metastatin, and they looked at the median overall survival, and they found significantly improved overall survival was 75 months versus 24 months in patients those who did not receive the mitastatin in the frontline setting. So that really tells you the significance of using FLT3 inhibitor in frontline as well as in second line setting. So relapsed and refractory FLT3 positive AML is really a big dilemma, as there is nothing that we can offer to these patients in our country. Salvage therapy is typically administered, and allogeneic stem cell transplantation is the only curative option. But in order for the patient to be fit for the transplant, they have to be in complete remission, or at least complete remission with incomplete recovery, or at least complete remission with partial hematological recovery. Tomorrow in my presentation, I will talk about in details about that trial as well as all the definitions of the response rates. But the current standard of care in the country, in Saudi Arabia, is the salvage chemotherapy, FLAG-IDA, FLAG, MET. All of you guys are using it, hypomethylating agents, but it's associated with very inferior outcome. So, I mean, in comparison to that middle trial data, so that's really tells us that there's an unmet medical need to have FLT3 inhibitors in relapsed refractory setting with the FLT3 positive AML, and there is very small window of opportunity with these kind of patients. So that's the take-home message, that FLT3 positive AML patients are associated with very poor outcome and current standard of care in the country.